Okay guys, this is going to be a little bit quicker than our anatomy PowerPoint. We're just going to talking about how we perform our carotid exams. This should be a little bit of just like an accessory to what you learned in clinical, but we're going to talk about some very particular things with this procedure itself. So capabilities, as with anything in the vascular world, we're able to highly pinpoint where a precise carotid lesion, stenosis or blockage could be. We can differentiate from an occlusion versus a stenosis. We can document progression of disease in patients that come to us every 6 months to a year. We can look for surface characteristics of our vessels, and we can evaluate pretty much for anything in that vascular world. So aneurysms, thrombus, embolism, dissection, carotid body tumor, all of that stuff we can do in one shot with this exam. Our limitations, on the other hand, dressing, skin staples, sutures, that's with anything in the vascular world, a little less likely up in the neck with the carotid, but still something that we can see if our patient has had an endarterectomy performed. We'll talk about that. Also the size and contour of the neck. Sometimes it's really hard when we get these big guys in there with these like wide, short necks. We can't really even fit the transducer in there. So that makes our job a little harder. Depth and course of vessel. Sometimes we have a very tortuous vessel where it goes in every which direction. And we can also very easily overestimate or underestimate the level of disease. So we'll talk about those as we go. You can kind of see some characteristics there versus overestimating and underestimating. Indications as to why we would perform one of these exams. Evaluating patients with any kind of neurologic symptoms. If we've heard something or we felt an abnormal pulse, if they're going in for surgery, we need to pre-evaluate those vessels. If they had any other kind of unexplained neurologic symptoms, if we're following up a proven disease, if they had their post-op, we can look and evaluate. We can do these during op, like intra-op. So we can go in with that vascular procedure and image while they're doing the correction. We can evaluate suspected subclavian steal, dissection, AV fistula, pseudoaneurysm, true aneurysm, any kind of carotid reconstruction after ECMO. ECMO is a life-saving form of life support. Not life-saving. Life support is life-saving, but it is a kind of last resort life support. So patients that can come out of ECMO are really resilient. Evaluation of syncope, seizures, dizziness, atherosclerosis, fibromuscular dysplasia, neck trauma, and then plaque visualization. Sometimes we get a lot of referrals from eye doctors because they see plaque in those ophthalmic or orbital arteries. So we can do a carotid to see where it's coming from. Patient position, really important. Supine with their neck extended. You want that neck up. So if you have a patient with a really short, wide neck, put a pillow, put a towel underneath their shoulders so that their head goes back even further. And you also want their chin turned opposite of the side that you are scanning on. Scanning techniques. Our 9 megahertz linear transducer. We start in transverse from our proximal carotid all the way up to our bulb and then into where it splits into our bifurcation. We're looking for plaque, dissection, aneurysm. SAG, we're doing the same thing. So proximal carotid from that clavicle region all the way up to the patient's mandible. We're looking in color, grayscale, and Doppler. We're doing velocity measurements with the PSV and EDV, and we're looking for any kind of abnormal flow directions. We're also evaluating the vertebral arteries in SAG, so we'll see what those look like as well. Physical principles, our spectral analysis, our pulse wave window. We use the fast Fourier transform. We should remember that from physics. So it's going to give us individual velocities and frequencies displayed on our time horizontal axis, as we are aware. Our continuous wave Doppler. This is not something that we're using, but a lot of echo techs will use it if they have to go up and look at the carotid. Don't really worry about it. It's when we have that one that's constantly receiving and constantly sending. We'll see what that looks like on our next slide. But we are going to be using our color Doppler and our pulse wave Doppler. So we're using one crystal to send, and then it's receiving once it's sent it out. It has range resolution. We can change the sample size depending on how wide the vessel diameter is. Gives us a nice well-defined spectrum. Very easy for us to measure the peak systolic and end diastolic velocities. And our color Doppler, as we know, it's going to assign color direction based on frequencies and the direction of that moving blood. So things that we're all very used to. Left-hand side, nice spectral analysis there. Sound like such a nerd, nice spectral analysis there. But we have our pulse wave Doppler, And then on the right-hand side, that's going to be our continuous wave Doppler. So you can see it kind of occurring both at the same time, whereas the pulse wave Doppler is taking those averages and giving us one nice visualization. Differentiation of ICA versus ECA. So we followed that carotid all the way up to the bifurcation, and now how do I tell which one is which? The ECA is going to stay more superficial. It's going to be angled closer towards the patient's face. It's going to be smaller. We're going to see branches coming off it. We are going to see a very high resistance, and you've probably seen some text tapping on the patient's forehead, right on their temple. It's called a temporal tap. It responds to that. So while we're Dopplering, if we tap, 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 tap on the patient's temple, we're going to see that reflected in that waveform. ICA, it's going to feed the brain, travels a little bit more posteriorly, deeper in the body, larger. It's not going to have any branches coming off in that neck region, low resistance, and it's not going to respond to the temporal tap. So here we have our nice bifurcation. We can see here, this top picture is typically what it looks like. This is what we call our tuning fork or our wishbone. This is what we would love to see in most patients, but we only see this in about 20% of them. So most of the time you have to angle either anteriorly to get the ECA or posteriorly to get the ICA. But in a beautiful world, you can see the carotid going right into that split. ECA is going to be more superficial. ICA is going to be more posterior, more deep. And then temporal tap responding in this picture on the right-hand side. They're Dopplering that ECA, and then this is going to be when the tech taps on their temple. Normal appearance, we want in our grayscale RB mode, we want to have a nice anechoic lumen with a hyperechoic wall. We're not seeing any soft tissue abnormalities, and we're just seeing continuous wall layers. We're not seeing any discontinuation between the different sections. Color nice and uniform, no bleeding, no ghosting, no mirror artifacts coming through. Dopplering, we're getting a nice clear spectral window, so we're not getting any spectral broadening. We're not having aliasing wrap around the top of our window. Our ICA is going to be a lower velocity and lower resistance than the ECA, and it's a little bit more continuous in its pulsation, whereas the ECA, it's going to be very high velocity, higher resistance, and more pulsatile. So let's take a look at what those would look like. So here we just have our nice example of our standard carotid. So we want to see nice smooth color. We want to see more so that picture on the right hand side in terms of color, but we could definitely turn that down. We're getting a little bit of that increased color gain, and then we also have aliasing that's occurring here. So color is better in this picture than these pictures. These pictures we're getting mirror artifact posterior to the vessel, and then we're also getting some bleeding and ghosting happening here. And then as for that pulse wave Doppler, we're getting that aliasing, which we know we don't want, so we want to be increasing our pulse scale. So this is exactly what they should be looking like. Nice anechoic vessel, hyperechoic wall, nothing going on in the lumen of those vessels. And then when we color it, beautiful, one color, uniform, no bleeding, no artifacts happening. Our pulse wave spectral analysis, nice beautiful waveform, no spectral broadening. So pretty good overall in terms of the B mode, color, and pulse wave. Here we have our ICA differences versus our ECA differences. Left-hand side is going to be our ICA, right-hand side is going to be our ECA. Our ICA is going to be a little bit less pulsatile, so we're going to see a little bit less of a strict waveform, and it's going to have a slightly higher end diastolic velocity. So if we look at this picture on the left-hand side, that EDV versus the EDV on the right-hand side, that's going to be the EDV there. It's much lower. It gets a lot closer to 0 with the ECA. And also look at that initial peak systolic with the ECA. Much higher, much faster acceleration time. ICA is going to be a little bit slower. Here we have our vertebrals. We see these at the posterior neck. So one little tip, I will show you this in lab, but one little tip for this is that we do a sag mid-carotid, and then we just angle back until we see the patient's bones popping in, their vertebral bones popping in, and then we see them like this on the left-hand side. We see these little segments traveling through those different vertebral spaces. So you want to show at least 2 of those so that you can prove that it is in fact the vertebral that's traveling posteriorly through the vertebral spine. And we Doppler it, beautiful. So This is showing what we don't want to do. So we've seen a lot of techs do angle correct. We don't want to do that, especially when we're looking at the carotid. Carotids, we are routinely following up these patients. Sorry about that. So we're routinely following up these patients. We don't want to implement a lot of variations between exams. So what one tech does versus what you do versus what the next tech does, you want to keep it all standard. So we want to keep our angle at 60 and then adjust our scanning. So on here, you see that that angle correct is coming up red on that right-hand side at the bottom. That is coming up as 71, right? We never want to angle correct above 60. If we have to change our angle at all, it has to be less than 60. It can never be more than 60. In a perfect world, you should not be angling at all. You should always keep that at 60. That's going to provide consistency. That's going to give us the most accurate angulation in terms of velocity processing with the machine. So you're going to see some techs kind of take the lazy way out. They're going to drop it down below 60 so that they can, make their lives easier. And it's technically fine, but it's not great. You want to keep it at 60 and then just change your scanning approach. So plaque, this is going to be something that's very hard for us to evaluate around, but you have to be aware of what it is. So this is going to be something that we can either see in a smooth sense or in a regular sense. Irregular plaque is a little bit easier for us to identify because it kind of pokes out a little bit more. Smooth plaque kind of layers in a way that makes it continuous with the surface, and it doesn't really draw our attention as much as irregular plaque does. So it's a little bit more discreet and inconspicuous. We want to be able to assess for texture of the plaque. So is it heterogeneous plaque? Is it homogeneous plaque? Is it really super hyperechoic? Is there plaque ulcerations in it, meaning that there's depressions within the plaque? Is there an intraplaque hemorrhage where we kind of see that plaque, depending on what it's made up of, kind of soften and liquefy over time? So there's all different types of appearances of plaque depending on what it's made out of, how long it's been there, and where it is. So picture on the top right-hand side is going to be more of our soft plaque, more homogeneous, kind of layering across the board a little bit more. And then we also have this hard plaque here, very hyperechoic, very prominent, pretty irregular. And down here on the bottom picture, this is all a variation of types of plaque. We have this plaque up here on the anterior aspect of the wall. We have this plaque down here that has that really hyperechoic little bubble of plaque that's shadowing. We have this irregular plaque over here. So a lot going on in that bottom picture there. So stenosis. If we see narrowing of a vessel, what are we looking for and what is it going to look like on our pulse wave Doppler? We know inherently we're going to see an elevated velocity and frequency. We're going to see spectral broadening. That waveform is going to get filled in. It's going to be ugly. It's going to represent turbulence and loss of that normal, healthy laminar flow within that vessel. We want to make sure that we're documenting the maximum velocity throughout the narrowest portion of that stenosis, and then we're also looking distal to the stenosis. We want to show those disturbed flow patterns, that kind of loss of energy distally to the stenosis, and kind of what's happening to those tissues further away. So all those tissues that vessel is going to supply are all going to be affected by that loss of energy. So we want to make sure that we're evaluating not just the stenosis, but also distal to it. So here, pretty straightforward example of pretty standard stenosis. We're looking at it in the most narrow part. We can kind of see it with that color display. where that color turbulence is occurring. We want to be sampling. We're getting that waveform here. Looking at our velocities, our scales are set to 500, so pretty high velocity. We're getting 432 centimeters per second. Spectral broadening, we don't have a nice clear spectral waveform window, and we're getting some flow reversal here as well. And lastly, how do we interpret the disease depending on what we see? So if we see any segment of a carotid, the ICA or the ECA, as less than 125 centimeters per second, it's normal. We don't care about it. We can have a slight stenosis that still comes in at less than 125 centimeters per second, but again, we're not really going to do anything. It's 1 to 5% stenosis, 1 to 15%. It's not really going to do anything for us. Now, 16 to 49%. This should say greater than 125 centimeters per second, but not taking into account any end diastolic velocity. So our end diastolic velocity could still be normal, right? Could still be within a normal range, but if our peak systolic velocity is greater than 125 centimeters per second, we need to start to follow that patient. We need to start to evaluate a little bit more. So that one should say greater than 125. Now, if we still have something that's greater than 125 for a PSV, and our EDV is elevated, but it's less than 140, that's going to be 50 to 79% stenosed. And then where we really get concerned is when it's still greater than 125, but greater than 140 for an end diastolic, we need to be concerned, right? That's going to be at a high risk of embolization, high risk of plaque breakoff, depending on what that stenosis is made up of. So those are going to be the patients that we are surgically going to most likely intervene with. Now, if we don't have any PSV or EDV in that section of the vessel, we're going to say that it's occluded. Occlusions, especially if it's a CCA, so a common carotid artery, may have a very low or absent end diastolic component, and that's because we're going to be getting a thump. That's going to be more of an artifact. So if our carotid is occluded, we may end up kind of picking up some kind of waveform, right? Like some kind of pulse, and that's just going to be artifact. That's going to be kind of the blood flow hitting up against that complete blockage, and it's producing this thump, thump, thump. It's like a knocking on the door, right? The blood flow is knocking on the door. It's saying, hi, let me in. And the door's like, no, I'm not opening. So it's knocking on that blocked occlusion. So again, pretty straightforward information here. These exams, once you know what you're looking at and what you're looking for, these exams are very straightforward, very simple, but it's very important to have precise Doppler skills. So we'll definitely be working on that as we go through this in lab.